Welcome, Rebel EM listeners, to another episode of Rebel Crit. I'm your host, Frank Lodeserto, and I am joined by
Dr. Eric Acker, one of the residents here at the program.
Today, we're going to demystify some of the devices used for non-invasive treatment of respiratory failure.
So this is the HiFlow nasal cannula, the nasal cannula, sometimes BiPAP, CPAP, but I think demystifying is a good idea because oftentimes as an intern, I usually start with, okay, the patient's having difficulty breathing, put them on nasal cannula. They still have difficulty, give them something more. And then I see it as a progression as an intern. And I think that's probably not the right way to go about this.
Well, I'll tell you a story, Eric. When I was an intern, I had a patient that was not doing very well and needed more support. The respiratory therapist turned to me and said, Dr. Lodeserto, do you want to put him on BiPAP or CPAP? And then I really didn't know. So I did the smartest thing I can think. I said, well, what do you think? And they chose something. And I said, sounds great. That's what I was thinking too. But I didn't want to admit, I'm kind of ashamed. I didn't want to admit that I didn't know the difference. And at that moment, it was the middle of the night. So I went and learned about it. So I think I have a pretty good analogy. I think we could talk about when to use CPAP or BiPAP, but really like, how do these things work? And I think I have a good analogy that I've explained to our residents before.
Okay, so let's start with, do you want to start with the analogy or do you want to start with how it works?
Let's just talk about the analogy. I could have heard it online, but I think I heard it from an old respiratory therapist a while back, and it always stuck with me because it was the clearest way to think about CPAP and BiPAP and how it works. The analogy is basically thinking of non-invasive, whether it's CPAP or BiPAP, like a hairdryer. You might say, that sounds very weird. So you have to kind of imagine you put a hairdryer and stick it in your mouth. So I wouldn't try this at home. This could burn your airway. I don't have much hair, but you could put it on cool mode, right? The whole point of it is giving you some pressure. So you got the hairdryer in your mouth, and CPAP, it's just one speed, whether I'm breathing in or whether I'm breathing out. The hairdryer, or in this case, the CPAP device, continuous positive airway pressure device, is giving me a continuous speed. It could be 5 centimeters of water, 10 centimeters of water, but it's just one speed. Whether I'm breathing in or breathing out, it's just giving that positive airway pressure. If I want two different pressures, now I'm getting into something called BiPAP, bilevel positive airway pressure. Now, think about the hairdryer analogy. I got a hairdryer in my mouth, and I'm struggling to get a good inspiratory tidal volume. I'm going to crank the hairdryer speed up to a high speed. So when I take a breath in, it's giving me more pressure. That is called the IPAP, or the inspiratory positive airway pressure. That's really helping offload my muscles and doing the work of breathing and giving me a bigger tidal volume. Then, as I exhale, I'm not dropping it down to nothing. I'm going to give them a lower, or an expiratory positive airway pressure called an EPAP. And that's going to be less, but still I'm getting some pressure from that. So in the hairdryer analogy, I go breath in, high speed, breath out, lower speed, in, out, high speed, low speed. And that's how I think about it. Now, the question is, when would we use that? I think it's confusing, but try to make this somewhat simple. And in the next episode, we're going to look at a new trial called the Renovate trial. And hopefully we'll have a guest on the show that reviewed this trial. And we're going to talk about the indications, but classically, the way I think about it is anyone's that's struggling really to get a breath in, low tidal volume, really tachypnic, low tidal volumes, I'm thinking about BiPAP. And if someone is just hypoxemic and I need some positive airway pressure, this could be someone with like atelectasis, not a whole lot of work of breathing, someone with simple pulmonary edema and not a whole lot of work of breathing. Chronically, this could be in patients with OSA, but I'm just going to give them that CPAP, that continuous positive airway pressure, to help recruit some alveoli and improve that shunt physiology, or open up atelectatic alveoli and improve gas exchange. And someone with BiPAP, like I just mentioned, when they're really struggling, short, shallow respirations, this could be someone who's hypercapnic and just struggling, tachypnic, not blowing off CO2. then I want to offload that worker breathing by giving them a higher or inspiratory positive airway pressure to get a bigger tidal volume. That bigger tidal volume ultimately should lower their worker breathing and decrease their respiratory rate. So we're going to really tackle the classic indications that are going to change a little bit or not. We'll talk about that Renovate trial. That's how I demystify it, using that simple hairdryer analogy.
Okay. And so then this other arm where we're not putting the face mask on the patient, we have the nasal cannulas, we have the non-heated nasal cannula, and we also have the heated high flow nasal cannula that we use for a lot of these patients as well. That's the other side of this non-invasive treatment.
Yeah. And one more thing, actually, you reminded me of something because you talked about putting a mask on someone's face. When I say non-invasive, some people could also think high flow. So I'll talk about heated, humidified high flow. Sometimes putting someone on CPAP or BiPAP could make them more comfortable because they can't breathe, so it can help them. But sometimes putting that mask can become quite restrictive. Now the patients can't cough up secretions. If it's in the case of pneumonia, they can't drink or eat, and you might not want them to drink or eat because you might want them NPO because they're on the verge of respiratory failure, but they couldn't clear secretions, couldn't eat and drink. But it's also maybe restrictive and very uncomfortable. So a lot of patients, compared to what we're going to talk about, heated, humidified high flow, find that BiPAP or CPAP is very uncomfortable. Have you seen that with your patients, Eric?
So many patients, they want to rip the CPAP off. They want the BiPAP off. And of course, there's a contraindication to just restraining the patient. So then you have the balance, this anxiety versus air hunger versus wanting to make sure that you oxygenate your patient appropriately without over sedating them.
Right. And you bring up a good point, sedating them. So we got a patient on the verge of respiratory failure. We'd like to put them on CPAP or BiPAP. But now we got to sedate them just to get them to tolerate the mask, right? So that also comes with risks because we don't want to sedate someone. We want them awake, breathing spontaneously. This is not a protected airway right now. So this is someone you're going to be more concerned about than if you intubated them and protected their airway. Now you have an unsecured airway and you're having to sedate them. And there's risks to that, hypotension. They could get altered, delirious, and they're on this mask. So this is actually a pretty high stakes procedure that we're going to put someone through, even though we don't think it as a procedure, placing them on CPAP or BiPAP. It could be high risk and somewhat terrifying for a patient and also for a physician watching this.
Oftentimes, depends on where you're at, what kind of floor you're on, the modalities you have available to you. Obviously, the acute floors, you have less options on as far as like Ativan, benzos. Whereas if you're in the ICU, you might have a little bit more things you can reach for, a little bit higher nurse to patient ratio that can keep a very close eye on these patients. So a lot of your anxiety management on these patients is going to vary quite a bit depending on where this patient's at.
Absolutely. And when it works, it works. Sometimes we use it transiently to pre-oxygenate our patient prior to intubation. That is a use too. Patients that are DNR, DNI, that they don't want to be intubated and you're using it more as a last resort, that could be used there as well. But again, the big point is I wanted you guys to understand a simple analogy of how it works, some simple indications, and I think we'll get more specific on next episode. And then it's not a protected airway. And there's some risk involved with placing someone on CPAP or BiPAP. So maybe we should spend the rest of the time talking about the settings real quick, because people do have questions on settings. When I usually set it up, honestly, it doesn't really matter how you set this up, which sounds crazy, right? But to give guidelines, please don't quote this and say you have to do it this way. It's a low to Certo method. But the guidelines are you should have a difference between the IPAP and the EPAP, somewhere at least 4 centimeters of water pressure for it to be really a difference, the IPAP versus EPAP. So let's say you were the classic 10/5, right? That's just a starting point. Then you really have to assess your patient and figure out what's going on. If you're trying to blow off CO2 and hypercapnia, we talked about in a previous episode, I want to give them a bigger tidal volume to help remove CO2. If the patient's oxygenating okay, maybe keep the EPAP alone. Maybe they have enough lung expansion, they're oxygenating well, but I want to give them a bigger tidal volume. Then I'm going to go up on my IPAP and make a bigger delta. If it was 5, now I'm going to increase it to see if that can give them a bigger tidal volume to blow off CO2. If I have a patient that is having low oxygen saturations and it's hypoxemia, then I might want to keep the delta the same, but go up on my EPAP, my expiratory positive airway pressure, to help with more lung recruitment. The delta is going to stay the same because their CO2 level might be okay. Ultimately, both are going to go up. And I guess the last scenario is they're failing on both ends. They got hypercapnia and they're hypoxemic. Well, then I'm going to increase my EPAP and increase my IPAP, but I have to extend my delta, make my delta larger so that I get a bigger tidal volume blowing off CO2, but I also want better recruitment with my EPAP. So both are going to go up and your delta is going to widen. That's general guidelines. I think that's good enough, at least for guidelines. Every patient will be a little different, but that's a little guidance of how to at least start it and what I'm looking for with my patient.
2 questions for you with that. So I think just like on ventilators, you can mess with the FiO2, which would be great for making sure they're oxygenating the patient. My main question is, do you touch the respiratory rate?
Yeah, well, FiO2, sure, that I shouldn't have not mentioned that. Of course, we can give them FiO2. I think we have to recruit that alveoli for that FiO2 to really diffuse across the alveoli. So that's the main thing. I'm guessing they failed simple oxygen cannula, and now we're on this modality. When I'm putting on a respiratory rate, this may be a patient I'm very worried about. If they can't breathe spontaneously on their own, I have to set a rate. This is someone who I'm very concerned. There are scenarios you may do this, but it's probably not common. I probably want someone who's spontaneously breathing, more awake, protecting their airway, and really generating spontaneous breaths, much like a pressure support mode.
I wanted to move over to the HiFlow nasal cannula because there's a little bit different with this one. There's a different mentality I think you have as far as possible PEEP, possible inspiratory pressures.
Sure. There's a little controversy on how much HiFlow can generate. If you look at different diagrams, HiFlow may generate something around the lines of what maybe a CPAP can generate, which is because it's a continuous liter flow. So think of it more like CPAP. There is some magic to it, which I'll get through in my mnemonic. It's not magic at all. I think it's all explainable by science. I did an early episode almost 5 years ago on a mnemonic I created called HiFlow, HiFlow. I may just reiterate that and bring up a few points about HiFlow. And classically, what we thought when you started someone on CPAP, it was for acute pulmonary edema, someone who has atelectasis, BiPAP, mostly for patients in COPD exacerbation, blow off CO2. And HiFlow was more reserved for patients with acute hypoxemic respiratory failure from pneumonia, because it really helped with secretion management. Now, the Renovate trial looks at some of these classic indications and may change the way we look at now when we can use HiFlow. I always said you could try HiFlow whenever if the patient is just not tolerating the non-invasive because it is uncomfortable. But let me go through the mnemonic, and I think it'll help you think about patients that might benefit from it. The first is the H in the mnemonic, and that stands for heated and humidified. So we were just talking before this. Usually people say you can't go beyond 6 liters of oxygen through a nasal cannula. The reason for that is you can, in fact, go ahead and crank it up if you're by the wall. Don't hurt your patient, but you can crank it up. It goes 15 liters. And then there's even beyond that, we don't know, maybe it gives up to 30 liters flush rate. Now, the thing about it is it's not heated. It's not humidified. And when you give these patients this oxygen, it's cold, it's dry. So keeping someone on 6 liters for a long time is really going to dry up their nasal mucosa. That cold oxygen may inhibit ciliary function, so you have less mucus production or remove less mucus. It can also cause a little bit of bronchoconstriction because it's cold air. When you walk in that cold air, it can cause some bronchoconstriction. Really, the magic behind heated, humidified HiFlow is the heating and humidification. It makes your ciliary function better, gets up mucus. If you want to go on really high liter flow, 50, 60 liters, depending on what device, the only way to make this tolerable for a patient is by heating it and 100% humidifying it. So that's the magic as compared to a nasal cannula. So that is the first letter, heating and humidification.
Then you have a way of thinking about the minute ventilation. These patients are breathing really fast, and how to think about going from these nasal cannulas at, let's say, 6 and improving their worker breathing by putting them on this HiFlow nasal cannula.
Yeah, that's good. My I is for inspiratory flow rate. So if you have a patient that comes in, let's say breathing, let's just give a rate, 40 breaths per minute. And let's just say they're breathing 400 cc tidal volumes, which is a decent tidal volume, but that's 16 liters in a minute. That's a 16 liter minute ventilation that this patient's wanting. So now we heat it and humidify this oxygen, and now I can crank up the oxygen as the liter flow rate to something like 50, 60 liters. So we're not only meeting their needs, which is 16 liters, I'm actually almost tripling it, right? I can't do math quick, but I'm more than doubling and almost tripling what they want. So if you come to your mom, dad, ask for money and they give you triple that, you're going to be so happy and you're going to leave them alone. Same thing for your patient. If you're giving this liter flow rate well beyond what they need, that respiratory rate should come down, that Tidal volume should also benefit. You're not struggling so much. So you're trying to meet their inspiratory demands by giving them that high liter flow rate. But the only way you can give them that high liter flow rate is by heating and humidifying that oxygen.
I'm going to carry on with your mnemonic a little bit, but so this one is, I think, the F.
F is for Frank, right?
No, the special sauce for treating patients. So the functional residual capacity. This is I think we think of it as PEEP sometimes from the HiFlow. Kind of explain this. Yeah. I was kind of concerned about this with the epiglottis not being.
I had to make this mnemonic, right? And so needed something for the F. So I creatively came up with functional residual capacity. Now, here's the thing. It's a little controversial. We don't really know how much PEEP. We think that every 10 liters of flow will give you roughly about 1 centimeter of water pressure of PEEP. But that is something we're estimating. The higher the liter flow, probably the more PEEP they're generating, but it's hard to measure PEEP in an open system. They've done trials where they try to measure in patients with tracheostomy prior to decannulation, but it's hard to estimate. What I like to look at is it causing end expiratory expansion of the lungs. So there's some great early studies that looked at people with impedance tomography, which is a non-invasive way to look at lung expansion. They looked at patients on room air with nasal cannula and on HiFlow. They saw is that as the liter flow rate up went on HiFlow, the lungs actually expanded. There was more end expiratory expansion and increased surface area as compared to room air, nasal cannula. So we do believe that going higher on the liter flow rate can generate some form of PEEP, but in my mnemonic, because I can't prove it's PEEP, but most people think that's the mechanism, it improves or increases the functional residual capacity and helps with gas exchange. So that's where I came up with that F.
And then I want to move into this. One of the biggest downsides of your nasal cannulas, HiFlow nasal cannula, regular nasal cannula, is that we do have this population of mouth breathers. That's not meant to be derogatory, but oftentimes people like to breathe through their mouth. And so you have this oxygen coming through the nasal cavity, but you're also getting a mixed amount of oxygen through the oral cavity. So how do we accomplish this with a HiFlow?
You can bring up a controversial point from the last point too. If someone is having open mouth, many people think that they lose some pressure when their mouth is open. I also think the larger patient, maybe someone with a larger body habitus, could be muscle, could be fat, they may get less liter flow. I think about this because kids, starting doses for someone with bronchiolitis might be 1 to 2 liters per kilo. So if you're a small baby, maybe just 6 kilos, putting someone on 12 liters, which for an adult doesn't sound like much, is going to be a very high flow rate. That's why I think it is dependent on whether the patient has their mouth open, that you might lose some pressure, the body habits of the patient, but somewhere around 30 liters, most experts say that below 30 liters, you may lose that positive pressure effect. To your point, the O stands for oxygen dilution. We did skip the L. The L is pretty simple. Compared to non-invasive positive pressure ventilation, CPAP, BiPAP, the L just means this is lighter. This is much more tolerable. So that's where the L comes in. And then the O is for oxygen dilution. This is really interesting. I talk about this with the residents a lot. If I put someone on a nasal cannula, what we say is, and this is a rough estimate, about every liter of oxygen gives you about 4% FiO2. So if I'm breathing 21% just by living on planet Earth, God put 21% around. If I put you on 1 liter, that's 21% plus 1 liter or 4%, that's 25. And you keep adding that up, 2 liters, 29, 3 liters, 33%. Does the patient really get 33% oxygen if they're on 3 liters through their trachea or getting onto their trachea? Well, there's a lot of oxygen dilution. Go back to my original patient, my patient that's breathing 40 times a minute, 400 cc tidal volumes. They have this simple nasal cannula on at 3 liters. They are sucking in a lot of room air around the nasal cannula, through their nose and through their mouth. So if they're sucking in oxygen from atmosphere, 21%, by the time that oxygen reaches their trachea, it's probably nowhere near 33%. It's probably closer to 21% because we say there's oxygen dilution. We learned the 1 to 4 rule from maybe a respiratory therapist or in medical school, but I think it's generally true if the patient is breathing comfortably just on oxygen. Now, what HiFlow does, though, is it puts 60 liters and it can go up to 100% FiO2. Even if you're breathing 16 liters and I'm giving you 60 liters at 100%, it's still going to have some degree of dilution. So the higher the liter flow and the more FiO2 you add, it will never get to where you think it will be, meaning because it's an open circuit. There's always dilution. If I have you on 60 liters at 100%, it's not going to be 100% because of that dilution, but it'll be closer to 60, 70. It's always going to be hard to tell. But because it's an open system, it's never going to be 100%. The great thing about HiFlow is it gives you a lot closer to what you think you're giving the patient, and there's less oxygen dilution.
And you're touching on it a little bit there. As the high flow oxygen level is going through the trachea, you are now oxygenating this airspace. This is now what we call anatomical dead space.
So that brings us to the final letter, which is W. This is something I don't think many people realize HiFlow actually does. And it's hard to describe, but I think I'm going to make this somewhat easy and demystify this for you a little bit, because what it does is causes CO2 washout, right? So if you can imagine, close your eyes, don't close your eyes if you're driving, but taking your hands and getting a bolus of gas. If you put that bolus of gas into and you suck it in an inspiratory breath, let's say it's somewhere like 500 cc's, which we learned, maybe about 350 of that breath, that bolus of gas, sits in the upper airway as dead space. Only 150 is used in gas exchange. Now, every time I breathe in, breathe out, and if I'm in respiratory failure, it's getting ineffective to breathe. I'm having a lot of what I'm going to call crappy gas sitting up in my dead space that I'm going to rebreathe. I'm rebreathing a lot of crappy gas, right? So now imagine I'm putting 60 liters into the nose. It's going to wash out all of that upper airway with almost 100% oxygenated gas, never 100%, but it's going to be almost near 100%. So every time I breathe, it's replacing all of that gas that was crappy, gets rid of the CO2, and it's making my breathing efficiency better. And I'm not rebreathing a lot of that gas that had CO2 in it. So it can actually cause a modest decrease in your CO2. And I think we'll look at that in the Renovate trial. These patients who classically were in COPD exacerbations, hypercapnic respiratory failure, which we were taught BiPAP is the treatment, which it still is, but it looked like HiFlow might have been non-inferior to that. So it might be something we substitute. Now, we'll look at that next week. There may be some evolving ways we can think about HiFlow, but it does get rid of CO2 and improve that washout of CO2. We've gone through quite a bit. Went through non-invasive, CPAP and BiPAP, talked about some indications, how to titrate it, and then we talked about HiFlow a little bit. One of the things I think about with HiFlow is that I want to start with a pretty high flow rate. Like I said, 30 liters is probably the cutoff where you may not be getting much of the benefit, but I try to start them out at a high flow rate. 40, 50 liters is probably the benefit, just to decrease their work of breathing and help. Then to titrate it, there's probably no great method. Actually, once they're better, you could probably come off quickly. So there's not a slow titration, but we want to make sure it's effective. So that's going to be your liter flow rate. It's all about the flow in this case.
And again, just underlying, this is a mechanism of treating respiratory failure. Realistically, we are bridging this patient on whatever the underlying etiology of the patient's respiratory failure, treating that first, managing them with this modalities, either that's BiPAP, CPAP, HiFlow. And then once they get better, you can back off.
We talked about there's nothing magical about a ventilator. It's just a supportive therapy to treat whatever disease process they have. Here, same thing. Whether we use HiFlow or BiPAP or CPAP, it's a supportive therapy, hopefully so we don't have to intubate our patients and be more invasive, and then give that patient a chance to get better and support their respiratory failure, whether it's hypercapnic, hypoxemic, or a mix. Yeah, that's why I said we're going to demystify this a little bit. Maybe the indications are changing. We'll look at the Renovate trial, but I hope that really helped our listeners understand how it's used, why we would use it, and maybe give some analogies and some mnemonics to help you understand it better.
Sounds great. Thank you so much. And next episode, hopefully have another guest that will talk about some new interesting studies.
Yeah, he hasn't got back to us yet, so I hope he does take us up. But thanks, Rebel EM listeners, for listening to another episode of Rebel Crit. We will see you soon.